recovered after gonadotoxic treatments. Even after recovery, their reproductive lifespan may be shortened. And if you look this one, the female survivor cancer are at risk of low serum image, elevated serum FSH, low neutrophil count, suffering from amenorrhea and also POI, and prolonging time to get a pregnancy. And then for the male survivor, also are at risk of low inhibin B, elevated serum FSH, suffering from severe oligospermia or azoospermia, failing report on recovery. It is because of gonadotoxic treatments. And so that's why recommendations Bill mentioned before discuss about fertility and fertility observations are very, very important. What is a POI? We know that POI is happen in a female below than 40 years old, characterized by absence of menstrual cycles, greater than or equal to 4 months, and then 2 sequential elevated serum FSH in the postmenopausal range. How big actually childhood cancer survivors suffering from POI or suffering from infertility? If you look these ones, the risk of non-surgical POI among survivors of children, adolescents, and young adult cancer survivor, approximately 8% by age of 40 years old. So that's why this is our patients. Very important that best practices for childhood cancer survivors that we should involving them consultations, the risk of gonadotoxic therapy, infertility, future obstetric risk, and also sexuality. And then childhood cancer survivor, they have risk of gonadal dysfunctions, should be screened when they should be referred to pediatric endocrinologists, andrologists, gynecologists, or fertility specialists if they want to get pregnant or to want to have a baby. In this figure, we can see the cumulative incidence of non-surgical POI that demonstrating increasing with advancing age and relationship to the gonadotoxic treatment. In A, we can see if the patient receiving alkylating agent only, and the B, when patient receiving abdominal pelvic radiotherapy, and C, which is the worst combination alkylating agent with abdominal pelvic radiotherapy. I think the highest incidence for the patient childhood cancer survivor to suffering from premature ovarian insufficiency. This is the type of chemotherapy and radiation Bill mentioned already. The highest is cyclophosphamide, more than above 9 grams per millimeter square in the dosage. In the very high risk, if radiotherapy more than 10 gray to the ovaries, and then also when the cancer patient receiving allogenic or autologous stem cell transplantations, and also hematopoietic stem cell transplantations. How about the male? This is also the drugs that associated with the male adverse reproductive outcomes. Cyclophosphamide in the equal dose. Again, this is the can-inducing impaired spermatogenesis, and then also testosterone deficiency, and also inducing sexual dysfunction. Radiation, moderate above 12 gray, can inducing testosterone deficiency, and other also surgery, of course, orchidectomy, unilateral, or spinal surgery. Sometimes they can also inducing sexual dysfunction in the male. How about the risk of subfertility after treatment of different types of childhood cancers? The low risk if the children with the cancer of acute lymphoblastic leukemia, Wilms tumor, soft tissue sarcoma, and the medium risk in the patient with acute myeloblastic leukemia, osteosarcoma, hepatoblastoma, and then high risk the patients with the whole body radiations, And also the children with Hodgkin disease, treatment with alkylating agent, soft tissue sarcoma stage 4, and Ewing sarcoma metastasis. So we know the drugs that very gonadotoxic, and also we know the type of cancer that has high risk to induce patients suffering from premature ovarian insufficiency. And then how was the gonadal function of females after they receive gonadotoxic treatments? This is, we can see among 48 females, there are, I think, 51%, they become a poor responder or diminished ovarian reserve with MH below than 1.19 nanogram per milliliters. And then during the cohort, the age at diagnostic, we can see 47.8% the patients were diagnosed at the age below than 13 years old. And then time since therapy, I think with cohort 53%, it has happened below than 5 years after treatment of gonadotoxic treatment, chemotherapy or radiation. And then some patients also need sex hormone replacement therapy. If you compare with the female, the boy, I think gonadal function in the boy after receiving gonadotoxic treatments, I think a little bit lower the risk, because only about less than 10%. There's a decreasing of testicular volume less than 15 cc, and also lowering testosterone, serum testosterone below than 325 nanogram per milliliters. And then again, 10% were diagnosis below than 5 years after treatment, and then also 7% the diagnosis they were diagnosed at the age below than 14 years old. So that's why this is our problem in our field of practice, that children who surviving from the cancer treatment, they have risk to suffering from premature ovarian insufficiency, or also suffering from oligozoospermia or azoospermia. And then the fertility surveillance among young female survivors of childhood cancer is quite varies. Not only the reproductive function, but also psychological well-being also affected, indicating that psychological parameters also important and should be followed, should be included in the follow-up. If you look this one, the tables, participants' quality of life, and then with the mood, anxiety, and depressions, we can see the quality of life. I think the lowest is the vitality, because the mean is only the mean score is 58 among the 90s, the highest, and then followed by general health, only 70%. That's the lowest, and also mental health. The score only about 73. So that's why the psychological also very important for the children that survive after cancer treatments. Anxiety and depression also, some of them suffering of anxiety and depression, I think 1/3, because the highest score is 19. They have around 6 and 7 the score suffering from anxiety and depression. How about the reproductive after surviving from cancer treatment? We can see in this study, I think from the green, I think the study cohort, more than 5,000 patients, the pregnancy rates, and then a little bit lower with a relative rate 0.81, then confidence interval below than 1, and then also another study by the same, hazard ratio 0.67, another study also by Seoul with the hazard ratio 0.87. Then how was the neonatal outcome after childhood cancer survivor treatment? We can see here, this is the biggest study, number of offspring, almost 4,700 born, I think, and then we can see health risk outcome. They found congenital anomalies, 129 offspring with congenital anomalies, so very low, because among 4,700. Also again in the Western Australia cancer registries, then from the 1,894 completed pregnancy, they found congenital malformation 12, and there is a sex ratio alterations among the offsprings. And the last also, I think 6,800 born, there is a congenital malformation were found about 220. This is the outcome. So that's why the key considerations regarding the fertility among childhood cancer survivors, early discussion is very, very important regarding fertility risk and options before the treatment begins. For prepubertal girls, it's very important. The main option actually for the fertility observation is OTC, ovarian tissue cryopreservation. Even can be used in the prepubertal girls, under 2 years. I think this is quite rare. The challenge is lack of mature sites, of course, and limited data on long-term outcome. The post-pubertal egg freezing, Bill mentioned already, and then with random option embryo freezing, of course they need sperm. And then if cancer treatment cannot be delayed, ovarian tissue cryopreservation may be the first choices. For medication such as agonist GnRH, still inconclusive for effective ovarian protection during chemotherapy. So very important technical advance for improving slow freezing or vitrification in the ovarian tissue freezing. For the male, I think it's more difficult compared to female, because in prepubertal boys, actually main option is testicular tissue cryopreservation, involving biopsy of testicular tissue, and then the post-pubertal boy, semen cryopreservation is the choices, unless sperm collections is very difficult or impossible. Of course, the testicular tissue freezing is become the first choices. I think this is for the male. And then how is the criteria for ovarian fertility observation, including childhood cancer survivor? We look the Edinburgh criteria for selection of ovarian tissue cryoobservations. Actually, the age should be below than 35 years old. Then no previous chemotherapy or radiotherapy before, unless patient below than 15 years old with previous low risk chemotherapy should be considered. Because if the patient already received, let's say, cyclophosphamide, of course the result, the prognosis is not so good. And then also realistic chance of survival years for the 5 years. Then the patient also have a high risk of treatment-induced immediate ovarian failure. Informed consent is very important from the patient or from the parents, and should be negative for infection. And then point for discussion for infertility or fertility observation with the patient or parents, according to the ASCO, discuss common concern, options, and then risk of delaying treatment. Cost also very important. Some country did not cover the cost of freezing fertility observation, but some country they covered. Actually, the procedure, the surgery to collect the oocyte, to collect ovarian tissue, laparoscopic surgery, they covered by insurance. And then the pregnancy risk after cancer. So, what should we do? Assessment in the post-pubertal survivors. So, of course, the first we should assess endocrine and fertility assessment. Any POI or not. And then later we do preconception assessment. If the patient suffering from POI, if they have cryopreserved oocyte or cryopreserved ovarian tissue, is very good. But if they don't have, of course, egg donation is becoming a choice. And if the patient not suffering from POI, we can assess whether the patient have a normal or low MH, which is conception or not, and then attempt natural conception or referring to infertility investigation. If they want to fertility later, they consider for doing freezing oocyte or ovarian tissue. Then preconception assessment is very important. Factors they may influence maternal health, and then compromised cardiac function, hypertension because of abdominal irradiation and gestational diabetes, and also factors they may influence fetal health. I think this is what we should do even in the post-pubertal cancer survivor. Then the progress in the therapy has made the survivor into adulthood. However, fertility counseling experiences among female survivors are underexplored. If you look this one, the communication challenge, information often confusing or incomplete, especially about female fertility and menstrual cycle, stress, and then inadequate counseling time, limited opportunity to ask questions, lack of professional support, and blah. Then, how was the current situation in Southeast Asia, in Asian countries, in established fertility treatment for children, adolescent, and young adult? I think this is our study across 11 countries in Asia. For children and adult, for children, fertility patient most likely not very often. And then the reason why not very often, because not enough information, lack of parents are reluctant to provide fertility patients, and then egg freezing I think becoming the choices, and then the semen freezing is not so easy for the boys. This is the situation in Asia. And then what is the barrier? The barrier is most likely the barrier is low recognition of FP among medical staff, insufficient information given regarding FP, low recognition FP society, and then problem with cooperation with pediatric department. This is very important. Unable to provide technology and weak evidence FP for children and adolescents. This is improving how we improving awareness of FP for children and adolescents. Things across 11 countries. I think oral explanation, illustrated book, article, and then movies become very important. This is how the situation. Who is the healthcare provider providing FP in children and adolescents in 11 countries? I think medical doctor and paramedical staff. The best is Australia. Bill mentioned about fertility, Japan, and then followed by Korea and Vietnam, and others now still facing a lot of challenge. So awareness and support is very important because the childhood cancer patient variable certified is quite varied. So most of them did not know even their fertility status, and then also we should anticipating the stress, increasing awareness, ensuring consistent counseling, and strengthening survivor support. And the last, what is actually our recommendation? Number one, this is I think general recommendation that survivor treated with one or more boron toxic treatments should be aware of the risk of premature ovarian insufficiency. Who needs surveillance? Who needs surveillance is the patient, the children who receive alkylating agent, cyclophosphamide, or radiotherapy. What's surveillance modality? FSH and estradiol is very good importance in prepubertal and peripubertal survivors to detect premature ovarian insufficiency. Then what surveillance modality in post-pubertal survivors? This is we should evaluating menstrual cycle. If there is menstrual cycle dysfunction, this is a sign of the first time for suffering from premature ovarian insufficiency. The MH, it should be used in conjunction with FSH and estradiol. And the last, when should pre and peripubertal survivor be referred? When should be referred? If there are no signs of puberty, by 13 years old, primary amenorrhea by 16 years old, and failure of pubertal progression. When should postpubertal survivor be referred? It's recommended refer to gynecology, reproductive medicine, or pediatric endocrinology. And then what should be done when abnormalities are identified? This is recommended refer to gynecology and endocrinology. And what should be done when potential for future fertility is questioned? So they should refer actually to onco fertility team, reproductive endocrinology or reproductive medicine subspecialist. So I think this is my last slide. Thank you very much for your kind attention.